Welcome to the deep dive. Let's jump right into a really key topic for MSRA revision. Indirect inguinal hernias.
Absolutely. Definitely one you need to know inside out.
Right,
Yeah.
so we've gathered all the essentials here. Our mission today is to give you a clear, concise, and hopefully memorable understanding.
Let's do it.
Okay, so starting with the basics, what exactly is an indirect inguinal hernia?
Well, in simple terms, it's when some abdominal contents, maybe like a bit of intestine, protrude out. They go through the deep inguinal ring.
That internal opening, yeah.
Exactly. And then they travel down the inguinal canal. Sometimes they can even reach the scrotum in men or the labia in women.
Ah, so it's taking that indirect pathway out of the abdomen.
Precisely. That's a good way to remember it, the indirect route.
Got it. And what causes this route to open up? What's the etiology?
Fundamentally, it's usually down to the inguinal canal not closing properly during fetal development.
Ah, back in development.
Yeah. That canal is the path the testes take when they descend. If it doesn't seal off completely, it leaves a potential weak spot.
Makes sense.
Yeah.
So that sets the stage. Are there things that make it more likely to actually happen later on? Risk factors?
Oh, for sure. Being male is the biggest risk factor. Older age increases the risk too.
Okay.
And then there's family history if it runs in the family. Also, anything that chronically increases pressure inside the abdomen, think persistent coughing or straining a lot.
Like with constipation.
Exactly. And finally, certain connective tissue disorders like Ehlers-Danlos syndrome can weaken the tissues, making a hernia more likely.
Okay, quite a few factors there.
Yeah, there's actually a useful mnemonic for revision. I think many adults frequently cough and have connections.
MAFCC.
Male, age, family history, cough straining, and connective tissue disorders.
Nice. That's helpful. Okay, so mechanically, how does the hernia actually, happen? The pathophysiology.
Right. So you've got that pre-existing weakness from the incomplete closure. When pressure inside the abdomen goes up, coughing, lifting, whatever it forces abdominal contents into that weak spot, the deep inguinal ring.
Pushes it through the opening.
Yeah. And then it just follows the path of least resistance, which is down the inguinal canal, alongside the spermatic cord in men or the round ligament in women.
Following that developmental pathway.
Okay.
Now, if someone presents with a lump in the groin, how do we differentiate this from other possibilities? What are the key differentials?
Good point. It's not always an indirect hernia. You've got to consider a direct inguinal hernia, which pushes through a different weak spot nearby.
Yeah.
Then there are femoral hernias, typically lower down and more common in women. In men, you also need to think about scrotal issues like a hydrocele or varicocele.
Right. Fluid or veins?
And crucially, if there's acute pain, especially in a younger male, testicular torsion is an emergency differential. So differentiating is really important for management.
Absolutely. How common are we talking here? What's the epidemiology like, say, in the UK?
Well, the incidence in the UK is roughly 27 new cases per 100,000 males per year. It's significantly more common in males than females.
And any peak age?
Yeah, it tends to peak sort of in the 40s and 50s, but can occur at any age, even infancy, due to that developmental origin.
Okay. So what would a patient actually notice? What are the typical clinical features?
The most common thing is a bulge or swelling in the groin. It might appear or get bigger when standing up, coughing or straining, and maybe disappear when lying down.
The disappearing bulge.
Exactly. There can also be groin discomfort or an ache, sometimes sharp pain, especially with exertion. Some people describe a feeling of heaviness or dragging in the groin area.
Right, that dragging sensation. Makes sense. How do we confirm the diagnosis then? Investigations.
Primarily, it's a clinical diagnosis, a careful history and examination, looking for that characteristic bulge, maybe asking the patient to cough or strain while palpating. That's usually enough.
So hands-on assessment is key.
Definitely. If the diagnosis is uncertain, or perhaps to rule out other things, an ultrasound scan of the groin is very useful. It can visualize the hernia.
And CT or MRI.
Less common for routine diagnosis. They might be used in more complex cases, or if there's suspicion of a complication, maybe preoperatively sometimes.
Okay, so once diagnosed, what's the management plan?
It depends. For very small hernias that aren't causing any symptoms, especially in older or frail patients, sometimes watchful waiting, just observation, is reasonable.
To keep an eye on it.
Yeah. But for most symptomatic hernias, or larger ones, surgical repair is recommended. That's called a herniorrhaphy, or more commonly now, hernioplasty, where mesh is used.
Mesh repair, open or keyhole?
Both are options.
Mm-hmm.
Open surgery or laparoscopic keyhole surgery. The choice depends on various factors, including the patient and surgeon preference. Sometimes, if surgery isn't an option, a supportive device called a truss can be used, but it doesn't fix the hernia.
Right, just provide support. What about the prognosis after surgery? Is it generally successful?
Yes, generally very good. Surgical repair is highly successful, especially with modern mesh techniques. The recurrence rate is pretty low.
That's reassuring. Are there any nasty complications we need to be aware of?
Definitely. Two main ones. First is incarceration. That's when the hernia contents get trapped and can't be pushed back in. It can become painful and irreducible.
Doc.
Stuck, exactly. And the more serious one is strangulation. This is when the trapped tissue's blood supply gets cut off. That leads to tissue ischemia and necrosis, which is a surgical emergency. Big red flag.
Okay, strangulation sounds critical. So, to quickly summarize for revision, indirect inguinal hernia. It's a protrusion through the deep ring down the canal, often due to failed fetal closure.
Right. Risk factors.
Yeah.
Male, older age, family history, straining, connective tissue issues. Remember MAFCC.
Got it. Presents as a groin bulge, may be painful, diagnosed clinically often with ultrasound backup.
Management is usually surgical repair, good prognosis.
But watch out for incarceration and especially strangulation.
You've got it. That covers the key points nicely.
Excellent. And for everyone listening, needing more MSRA resources, do check out pastthemsra.com and also freemsra.com.
Definitely worth a look. And just a final thought to mull over. How does knowing about the descent of the testes during development really solidify your understanding of why an indirect inguinal hernia follows that specific path in males?
Something to think about. Great stuff. Thanks for that deep dive.
My pleasure.
Catch you all next time.